there is another topic which we'll do now, esophageal caustic injection. Why we are taking this topic? First point, it is given in recent Bailey, and we have not received questions from this topic in the recent years, but I personally feel that it is a very relevant topic, so we should go ahead with this. Most common corrosive ingestion is alkali. The two type of acids which are two types of corrosives or caustics which are commonly used are alkali or acid. Generally people prefer alkali because it is tasteless. We person can take more amount of alkali, and acid is very difficult to take. Alkali causes liquefactive necrosis. Alkali liquefactive necrosis. Okay, now whenever a person is taking either alkali or acid, there will be damage to whole esophagus, and there will be damage. In case if some of this alkali or acid reaches to stomach, it can also damage to the stomach also. Okay, so the findings will be, what we'll do, we'll first go for upper GI endoscopy in these patients. Upper GI endoscopy. After upper GI endoscopy, we will grade the injury, grading of injury based on endoscopic findings. And what is the grading of the injury? It is given in Bailey, it is important. The first is normal, this is grade 0. Then grade 0 is normal. Grade 1 is superficial edema. Grade 2 is mucosal or submucosal ulceration. Grade 3 is full thickness ulceration, transmural or full thickness ulceration. And grade 4 is perforation. Okay, grade 4 is perforation. Okay, this is important to understand. And generally, normal finding, there is no need to do anything, just observe the patient for a day and then can be discharged. In case if there is superficial edema, then it will be managed with conservative management. Generally this perforation needs emergency surgery. This grade 2 and 3 will need a feeding jejunostomy. Okay, because the patient will not be able to take orally. Later on the patient will develop esophageal stricture. With the possibility of gastric stricture also, with or without gastric stricture, and will not be able to take solids or even liquids in many cases properly. Okay, so this is a barium picture in which we can see there is long segment esophageal stricture. After corrosive ingestion. Okay, so in cases of corrosive esophageal stricture, the treatment is, if the stricture is short, we will go for endoscopic dilatation. If the stricture is very long or failure of endoscopy, we'll go for surgery. And generally what we do in surgery is, suppose there is a long segment esophageal problem. In many cases there is some involvement in stomach also, so we will do a colonic replacement where we will do a colonic bypass. We will not resect stomach, we will prefer a colonic bypass. So in majority of cases we will go for esophago coloplasty or a colonic bypass, which is the preferred one. Okay, so there is a very common question in benign esophageal strictures, like in peptic stricture where there is a problem in stomach or there is reflux disease, and in cases of corrosive esophageal stricture, the conduit of choice is colon. Okay, the conduit of choice in benign diseases like peptic stricture and corrosive stricture. The preferred conduit of choice is colon. Which colon? Left colon. Okay. This is what is preferred conduit of choice in these cases. Okay.